Now let's take what we've learned about lipids and lipoproteins, biological markers, and imaging of subclinical disease, bring it all together, and evaluate a typical case that you'll see in your clinical practice. This is a 50-year-old physician with his first visit to the office. He has fairly average lipids, in fact, a little better than average in that his LDL cholesterol is only 110 milligrams per deciliter, atypical chest pain. He's in suboptimal physical condition. He's overweight. His diet is poor. A doctor that he had seen prior to the visit with me had done a nuclear stress test which was negative. And let's remember that that nuclear stress test being negative simply tells us that he does not have a lesion in his coronary artery that is greater than 70%. He could have 50% lesions and he'll have a negative nuclear stress test. So we really don't know the status of his coronary arteries other than the fact that he doesn't have obstructive disease. His Framingham risk score was only 2%. So one might simply say this is a gentleman who needs no further attention, is at low risk, or we have the opportunity to use what we've learned and take a deeper look into the different elements that we've learned about and then develop a much sharper image of this patient's risk. So next we look at other lipids and lipoprotein and biomarker and risk markers and risk factors that will add to what we've already learned from our prior evaluation, our simple evaluation. So let's look at the highlighted figures. We have a triglyceride of 182, so that is high, but it's not terribly high, and that's part of a normal or a standard lipid profile. You wouldn't be sort of scratching your head now and saying, oh my God, this person is at deep risk of having an event, but look further. The LDL particle number is almost 2,200, and that is exceptionally high. Remember, an LDL particle number of 2,200, if you had that 10-to-1 relationship that you'd find in a population, would give this person an LDL cholesterol of about 220. Now, if you saw a patient with an LDL cholesterol of 220, that patient would likely have FH, or familial hypercholesterolemia, a very severe genetic disorder that can lead to premature cardiovascular disease. That is not what this patient has, but that's what you would be thinking. So the risk inherent in an LDL particle number of 2,200 is very high. The patient also has a high lipoprotein-associated phospholipase A2 of 273, a high myeloperoxidase, another biological marker, a high oxidized LDL, and a high urine microalbumin, which is kind of a poor man's guide for endothelial function. So now you're getting the sense with multiple biomarkers and risk factors that are abnormal, you're getting the sense that this person actually is at great risk. And here you see a coronary CT angiogram of the left anterior descending coronary artery with multiple mixed plaques. So this person is at risk for cardiovascular event. So in conclusion here, the simple lipid profile actually failed to reveal this individual's risk, while knowing much more, evaluating biological markers, evaluating other risk factors, assessing for subclinical disease, justified far more aggressive management of what would have been an otherwise hidden risk. We have therefore illuminated the invisible in this patient. Our response then would be to really ramp up therapeutic lifestyle changes and utilize aggressive risk reduction with medications as well. Typically, this patient would be on a statin or combination therapy if necessary. Of course, aspirin, we'd consider ACE inhibition, the omega-3 fatty acids, DHA and EPA at 1,000 milligrams a day as per the American Heart Association recommendations, obviously weight loss and daily exercise, and this person definitely requires close follow-up. What we'll find is that the patient's numbers will improve, and they'll improve quite dramatically. So in follow-up, lipids, lipoproteins, and the biological markers will show total cholesterol of 110, LDL cholesterol of 53. More importantly, look down at the LDL particle number of 770 and the Lp(a)2 of 126, markedly improved from previous labs. So as a final thought, I'd like to say that we have entered the era of interventional prevention, and novel and well-vetted tools are now in our armamentarium and enable us to dynamically address and mitigate many of the root causes of atherosclerosis. And by doing everything that we've discussed today, this is how we practice preventive cardiology of the future, truly patient-centric interventional prevention. Thank you once again for joining us today for our discussion of interventional prevention.